Ladies and gentlemen, it's a real pleasure to stay with you in Tel Aviv, to share this thought with you. And I'm thankful for the presidents of this meeting and for the Grappa friend for inviting me in this very interesting meeting and beautiful site. The treatment of psoriasis of moderate to psoriasis should consider taking into account that psoriasis is a lifelong disease requiring long-term treatment. In particular, moderate to severe psoriasis requires systemic treatment. We classically divided the systemic treatment in conventional systemic treatment, which include methotrexate, cyclosporine, retinoids, acitretin, and fumaric acid esters, which are used mainly in Germany and UK. I don't know if in Israel we use fumaric acid ester. No, you don't use. And phototherapy. And then we have biologic systemic treatment, which include adalimumab, etanercept, infliximab, and ustekinumab. Tomorrow, we will discuss the new treatment, including new biological treatment for psoriasis. Long-term psoriasis control is still an issue. Why? Because in some patients, systemic treatment could have a lack or loss of efficacy. So, continuous versus intermittent treatment of psoriasis. The choice of continuous versus intermittent greatly depends on the drug is being prescribed. What do I mean? I mean that for conventional systemic treatment, major limitation for continuous and long-term treatment is cumulative toxicity. Liver toxicity from methotrexate, renal toxicity from cyclosporine, and skin carcinogenesis from phototherapy. In contrast, for biologics, continuous treatment has a greater efficacy and also a greater safety compared to intermittent treatment. And all this presentation will discuss this point with you. I think that you will agree that phototherapy is commonly used intermittently and as needed in case of psoriasis flare. And why? Because PUVA is a well-established risk factor for skin cancer, including melanoma cancer, including squamous cell carcinoma. Indeed, there are recommendations to limit the lifetime cumulative UV exposure to no more than 1,000 joule per square centimeter. What about cyclosporine? Cyclosporine is widely used in Italy. I think less used in UK and United States. I don't know what about here in Israel, if it's widely diffused or not. We can discuss this point. Cyclosporine is very effective, is a rapid effective, but is an adequate treatment for medium terms. Treatment. It is adequate for months. It requires extensive laboratory monitoring. It has several contraindications, including hypertension, dyslipidemia, and drug interaction. And the safety issues are mainly those related renal diseases and hypertension. Cyclosporine is effective in most of clinical types of psoriasis, not only plaque psoriasis, but also pustular psoriasis, erythrodermal psoriasis, nail psoriasis, psoriatic arthritis also. And generally, we use cyclosporine intermittently. What do I mean? I mean that we have an initial dose generally of 3 milligrams per kilo per day. Then we have the clinical remission, and we up to 8 or 12 weeks of continuous treatment, and then we stop the treatment. Generally, we taper the dose of the treatment progressively until withdrawal. Then we have a time without treatment, and in case of flare of psoriasis, we have another course of treatment. And we tend to repeat these courses of cyclosporine until when? This is a study from Greece, and they compared the efficacy of intermittent versus continuous treatment for up to 1 year. And they found that continuous regimen is more effective than intermittent treatment. They used the PASI 75 response, and 92 patients reached the PASI 75 response after 1 year compared to 62 patients of those on intermittent use. There were no significant differences concerning the quality of life, and obviously the total dose was less of cyclosporine was less in the group of intermittent treatment. These are the main safety concerns for long-term treatment with cyclosporine, and they include renal toxicity, hypertension, neoplasm, hyperlipidemia, hyperkalemia, hyperglycemia, and also, in my experience, I find also hypertrichosis, gingival hyperplasia, and paresthesia. I will show you some picture of hypertrichosis on long-term psoriasis treatment. And also I found that this is also very frequent, is a hyperplasia of sebaceous gland. And gingival hyperplasia. Moreover, cyclosporine affects deeply metabolism, and this is a study from the PSOCare registry, which is the national registry, Italian registry for psoriasis. We investigated the development of metabolic abnormalities in patients enrolled in this registry. And regarding cyclosporine, just to focus the attention on cyclosporine, we found that the use of cyclosporine at week 52, so after 1 year of continuous use, cyclosporine increased the relative risk of developing hypertension and also diabetes. This finding of diabetes is very interesting because it is also reported in transplanted patients. So a question for you. What is the maximum period for which cyclosporine should be given to patients responding to treatment? And this is a consensus, international consensus. We have participated from the leader of this project was Uli Morawiecz from Germany. And we agreed that the use of cyclosporine is intermittent until induction of clinical response for courses over 3-6 months. When necessary, cyclosporine may be given to patients responding to treatment continuously for up to 2 years. And again, the long-term use of cyclosporine should be considered with caution because of the significant risk of renal toxicity, arterial hypertension, and increased risk of skin cancer, particularly in those patients who were previously treated with PUVA. And we have also our friends from the American Academy of Dermatology, who recommend that the treatment of cyclosporine should be kept below 1 year. In Europe, we consider 2 years, but I think that the message is that cyclosporine, the use of cyclosporine should be monitored for the safety issues and limited in the time. What about methotrexate? Methotrexate is the most used systemic treatment for psoriasis in Europe, US, and Canada. It's effective in psoriasis and psoriatic arthritis. It is cheap, that is very good point in this time, is convenient and is suitable for long-term treatment. It requires laboratory monitoring. There are several contraindications. I will discuss this point, particularly for liver disease and alcohol consumption and also obesity. And there are safety issues in psoriatic patients, particularly for continuous use. This is a Kaplan-Meier curve, a prospective study, showing you the risk of liver fibrosis in patients receiving methotrexate on continuous basis. And this line shows you that this risk is significantly increased in those psoriatic patients with at least one of the following risk factors for methotrexate liver fibrosis, which include overweight, high alcohol consumption, diabetes, or viral hepatitis. And I would remark that the fatty liver disease should be considered at the baseline before initiating the therapy with methotrexate in psoriatic patient, because NAFLD and NASH significantly contribute to the prevalence and progression of methotrexate-induced liver injuries. And I believe that is a very important point, because the non-alcoholic fatty liver disease is very frequent in psoriatic patients. This is our patient, and we found that the prevalence of NAFLD was 48% of the population, of our population. Very recently, on the American Journal of American Academy of Dermatology, was published another paper by the Dutch group, confirmed that 46% of their population had non-alcoholic fatty liver diseases, and particularly those patients with a PASI score greater than 10, so the moderate to severe psoriasis. And again, it's very important to monitoring for liver fibrosis in psoriatic patients. These are the recommendations from the American Academy of Dermatology, and they recommend that for patients without risk factor for hepatotoxicity, liver function should be evaluated monthly for the first 6 months and every 1 to 3 months thereafter, with stricter guidelines following prolonged use, including liver biopsy, after 3-4 grams of cumulative dose. These are the European recommendation. We didn't include the liver biopsy routinely, on routine base, but we did include the FibroScan or the measurement of serum level of P3NP as a measure for liver fibrosis, a biomarker of liver fibrosis in patients treated with methotrexate on long-term use. So, the other question is, what is the maximum period for which methotrexate should be given to patients responding to treatment? Again, I report the same consensus I mentioned you before, and methotrexate may be given for how long as it remains effective and well tolerated. Screening and monitoring of patients according to existing guidelines is required, and in most cases the risk of liver toxicity is low. However, the impact of additional risk factors should be considered, including alcohol intake, obesity, and fatty liver disease. So can conventional systemic treatment be stopped in case of sustained response or clearance? Continuous therapy is required to achieve long-term disease control. Therefore, stopping therapy is not generally recommended. However, if agreed with the patient after reaching a clinical remission of psoriasis for at least 1 year, stopping the treatment could be considered when, according to patient preference, according to the absence or presence of comorbidities, including PSA, according to the quality of the impact of quality of life of the patient, according to the type of treatment, and also the availability of treatment option in case of disease recurrence. So we were used to use systemic conventional treatment in a rotational way. So we use cyclosporin, then we stop, we go with methotrexate, we stop, we go for tetracycline and then acetylcholine. This is to reduce the cumulative toxicity of the conventional treatment. However, with the use of biologics, we have this condition. We have that this is a retention rate of systemic treatment for psoriasis comparing the retention rate of conventional to TNF inhibitors, TNF blockers. And in my experience, I found that with TNF blocker, I have a higher retention rate compared to conventional systemic treatment. Generally, I stop this treatment on long term because of safety issues. With TNF blockers, I can go on. And so, moreover, we have from literature several studies in which TNF blocker were compared continuous versus intermittent regimen. This is for infliximab, for instance. We have at least two important clinical trials, RESTORE-2 and EXPRESS-2. They intentionally compared the two treatment regimens, and they did found that the PASI 75 response rate is significantly higher in the group of continuous treatment comparing to the group of intermittent treatment. Moreover, the RESTORE-2 trial was terminated by the sponsor due to adverse event, particularly severe infusion reaction and serious infection, which were more prevalent in the group of intermittent treatment compared to continuous treatment. And those patients were positive for antibody anti-infliximab. Then we have also the EXPRESS-2 trial. We have the data. The blue histogram, the blue column, is the PASI 75 response rate, 78%, in the group of continuous treatment versus 57% of PASI 75 respond in the group of intermittent treatment. So there is no way the efficacy is higher when we use this treatment on continuous basis versus intermittent. And this is the similar feature for PASI 75 response rate in the RESTORE-2 trial. This is the line of continuous treatment, and the proportion of PASI 75 responder is higher if compared to the dot line of intermittent regimen. What about adalimumab? This is a study where, in which to evaluate the efficacy and safety if interrupted after clinical remission. So the design of the study is different compared to the study I showed you before of infliximab. And then adalimumab was resumed in patient after the relapse of the psoriasis. The first data is that 72% of patients relapsed after the withdrawal, after 20 weeks of adalimumab withdrawal. But upon resumption of adalimumab, 69% reachieved a PGA of clear or minimal compared to 89% of those on continuous regimen. So again, the continuous use of adalimumab is more effective than the intermittent regimen. Moreover, withdrawal was significantly associated with a greater risk of formation of anti-adalimumab antibodies. What about etanercept? There are at least two important studies comparing continuous versus intermittent. And this from Moore and this from Ortol, the CRYSTAL study. I will show you data on the CRYSTAL study. This is the design of the study. Patients were randomized in two groups. The first group was continuous. The second group was paused after the first induction regimen until remission. And then in this group, in case of relapse, the patient were retreated with etanercept. And these are the results. The proportion of improvement of PASI is significantly higher in patient on continuous treatment compared to intermittent treatment. And similar features we have with the DLQI improvement, significantly higher in the group of continuous treatment versus intermittent. Similarly, the PGA, Physician Global Assessment, is less in the continuous versus intermittent. This was the primary outcome of the study. Regarding safety, the serious adverse events were more frequent in the group of paused comparing to continuous regimen. So, clinical studies show greatest clearance and fewest adverse events with continuous compared to intermittent therapy. After etanercept withdrawal, relapse typically occurs after 12 weeks. However, for etanercept, most of the patients, 80% of the patients, regain their response after reinitiation of etanercept. We have a few data regarding ustekinumab. It's the Phoenix 1 trial. And at week 40 of the Phoenix 1 trial, the group 1 and the group 2 were randomized. The first arm received placebo, and then in case of relapse, retreatment. The second arm received ustekinumab 45 milligram or 90 milligram on continuous based. And the result was that in case of withdrawal of the treatment, the psoriasis recurred compared to the continuous treatment. So the last question is, can biological therapy be stopped or interrupted in case of sustained response or clearance? Stopping biological therapy is not generally recommended. Biologic therapy should be generally administered on continuous treatment. However, if agreed with the patient and after achieving a complete remission for minimum 1 year, stopping biological therapy can be considered with careful follow-up, and we should consider the patient prevalence. We should consider the absence of significant comorbidities, including psoriatic arthritis, the low impact of disease on quality of life, and no worsening of disease after previous dose reduction or treatment withdrawals. Another consideration is that the risk of antibody formation against biological therapies increases with intermittent therapy, and this is particularly true for monoclonal antibodies, infliximab and adalimumab. So in conclusion, this is my use of systemic treatment for psoriasis I prefer. I go for intermittent treatment for phototherapy, cyclosporine, and azacitidine. I definitely go for continuous treatment for infliximab, adalimumab, and ustekinumab. And then in the borderline, it depends on several factors, but I can select etanercept or methotrexate for intermittent and continuous treatment. So in conclusion, continuous therapy for psoriasis is generally required to achieve long-term psoriasis control. The choice of continuous versus intermittent treatment greatly depends on the drug is being prescribed. Generally, for conventional therapies, the major limitation for continuous treatment is cumulative toxicity. In contrast, for biologics, continuous treatment has greater efficacy and safety compared to intermittent. And the last slide is an invitation for you to Verona in April this year In April, generally the weather in Verona is nice, like in Tel Aviv nowadays. And because this is a very interesting meeting on the skin, immune-mediated inflammatory diseases, and not only psoriasis, but also lupus, scleroderma, vasculitis, and hidradenitis, atopic dermatitis, and autoimmune bullous diseases we will discuss by different experts. I thank you very much for your attention.